This is Robin Grant with the National Consumer Voice for Quality Long-Term Care, and I want to welcome all of you to today's webinar entitled Engaging Ombudsmen, Residents, and Families as Partners in Preventing Catheter-Associated Urinary Tract Infections, which we're going to call CAUTI. So the goal of this webinar is to provide you with information about a really exciting and successful project that we've been working on for about the past year to educate local ombudsmen about CAUTI and raise awareness and understanding of CAUTI and infection prevention among nursing home residents and their families. Here's what we have planned for today's webinar. Next slide, please, Alicia. So following introductions, you'll hear from Sue Collier, who's with the Health Education and Research Trust. And Sue will talk about the Agency for Healthcare Research and Quality Safety Program, and we call it ARC for short. So ARC Safety Program for Long-Term Care that relates to CAUTI and also relates broadly to healthcare associated infections, which are referred to as HAIs, all this alphabet soup, so we apologize for that. But Sue's going to talk about the big kind of umbrella project that included education of literally hundreds of nursing homes, as well as our project with ombudsmen, residents, and families. After Sue, I'm going to tell you about our project, including Consumer Voice's role, the role of the state ombudsman programs that participated in the project, and then spend a little time talking about the general role of the ombudsman in terms of CAUTI prevention. After that, we're going to get to the heart of the webinar, which is hearing from Sherry Culp, who's the Kentucky State Ombudsman, and Joe Rodriguez, who's the California State Ombudsman, about what they did in their states during this project. And finally, we'll give you a chance to ask questions, and then we want to share with you what you can do to promote CAUTI prevention. So in terms of introducing our speakers, I think most of you know me and your colleagues Sherry and Joe, but I don't think you know Sue. So let me just say a few words about Sue. She serves as a clinical content development lead for the American Hospital Association Health Research Educational Trust. So in this role, she provides clinical content leadership for several national quality improvement projects. So this one, the long-term care HAI and CAUTI project, but also other projects that include Teen Steps, CDC, and ambulatory surgery center programs. She's led numerous clinical and executive leadership positions. She's led national and state initiatives to improve patient safety performance, and she has done a lot of work around patient and family engagement. And Sue's passion for patient and family engagement comes from a very personal level, because she also had a mother in a nursing home for, I think it was 9 years. And she knows firsthand what it's like to be a family member advocating for quality care. So there's a lot of information that we want to share with you today, but I just want to cover a few logistical details before we begin. So right now, all of your lines are muted, so everyone can hear the presentation without background noise. We will answer questions at the end, but if during the presentation you have a question and think would like to ask it right then, you can certainly do that by using the chat feature on your screen, which you should have on the right-hand side of your screen. There's a box that says chat. There is also a place that says questions on the right-hand side of your screen as well, and we ask that if you have questions about the materials or the PowerPoint or anything like that, that you use the question feature, but for questions about content, we ask that you use the chat feature. So in addition, the webinar is being recorded, and we will make both the webinar recording and all the PowerPoint slides available after the webinar. We'll also be sending you the link so you can access all the handouts and resources that you'll be hearing us talk about today. So I think that covers all that we need to talk about at this point. So next slide, please. So let's get started by hearing from Sue. So Sue, I'm going to turn it over to you.
Sue, you might be on mute.
So I'm not quite sure what's happened to Sue. We will certainly try to reach her. I didn't know, Ashley, if would you possibly be able to kind of pinch hit for her?
Yeah, sure. So HRET is a nonprofit part of the American Hospital Association. You can see that we've been around for quite a while. We do a lot of work on patient safety projects with hospitals and other types of healthcare facilities around the country, usually through large-scale dissemination projects and contracts through the government. Next slide. So one of the particular contracts that we've been working on for the past 3 years, really, and our contract ends next month in September, so it's been quite a journey for us, is the ARC Safety Program for Long-Term Care, HAI's CAUTI. We've reached over 500 long-term care facilities, pretty much in every state across the country, through 5 different cohorts, and you can kind of see there the reach of the project. And so we recruited different types of organizations, state-based hospital associations or healthcare systems, and they recruited facilities into a 12-month program using evidence-based education and different types of interventions, and then measuring both the HAIs, the CAUTIs at the facility, as well as different resident culture safety practices. We partnered with... Oh, hi, Sue.
Hey, I'm so sorry. I could hear everything that was being said, and I was not muted, so I just called back in. I apologize.
No worries. I'm glad it works. So if you want to take over, Sue, and talk a little bit about the project and the focus on CAUTIs particularly.
Sure, and I do apologize, but I was talking and unmuted, so I don't know if there was just... Technology is a lovely thing, and sometimes it's not a lovely thing. So thank you so much. But it sounded like, Ashley, you're doing a great job of providing the participants today an overview of this program. But as I heard Ashley say, this is a program that has been national. It's involved not only a large number of long-term care facilities, but it's really been one of the largest performance improvement programs that we know of that's been implemented with long-term care facilities. And the program itself, while it was focused on catheter-associated UTIs, it was really about having an opportunity to help long-term care facilities develop a strong foundation in overall infection prevention practices and antibiotic stewardship to eliminate as many, if not all, healthcare-acquired infections as possible. The program itself was organized to partner with national experts in the field of CAUTI prevention as well as healthcare-acquired infections, and also national experts who have worked with long-term care facilities to help them improve their overall culture of safety. HRET disseminated the education for the program through organizational leads. These are individuals who volunteered and to serve in this leadership role, and they worked directly with long-term care facilities, recruited those facilities. Many of those were within their state. In some cases, org leads covered regional areas or corporate organizations, and those org leads worked intimately with leaders in long-term care facilities to share the information that was in the program that was developed specifically for staff and long-term care facility leaders to help them translate the concepts of infection prevention, particularly prevention of catheter-associated UTIs. And on the next slide, I think it's really important for us to level set and recognize that this project mattered not only to the leaders that we worked with, but ultimately to the residents that we serve, because we have an issue with healthcare-associated infections in nursing homes. And as this slide shows, the statistics are pretty staggering. It's anywhere from over 700,000 to 2.8 million healthcare-associated infections occur annually. And it's estimated that over 380,000 nursing home residents actually die as a result of these infections every year. And when we looked at the infections that were cited in this research, what we saw was that urinary tract infections was one of the most common healthcare-acquired infections that occur in nursing homes, and they're also one of the most frequent causes of transfers and readmissions from nursing homes to acute care hospitals. And when we looked at the number of hospital patients who were transferred to nursing homes, we saw this huge incidence and prevalence of urinary catheters. And we know from the research that if you have a urinary catheter, you exponentially increase the chance of getting an infection. And so the overall goal of this project was to improve safety for nursing home residents by targeting the prevention of CAUTIs, and specifically, where possible, preventing the insertion or use of urinary catheters whenever possible. So we did this. On the next slide, we have a diagram that shows you at a very high level how we developed the content, the education for this particular program. And we've broken into two segments, clinical interventions and cultural interventions. In the clinical interventions, we focused on things like the evidence-based infection prevention practices that we know were proven to prevent catheter-associated urinary tract infections. So things like removing a catheter when the indications were no longer met, or making sure that if a resident did need an indwelling urinary catheter, it was inserted using a septic technique. And then encouraging staff to use regular assessments and to participate in training so that when the resident did need a catheter and they had a catheter, that we would be constantly looking at making sure that catheter was maintained properly to prevent infection, and constantly being assessed for readiness to have the catheter removed. And then last but not least, incontinence care planning. That was identified as a major opportunity to assure that residents were receiving the best care possible without a catheter, and that if they did have incontinence, that was not a reason solely for in placing an indwelling catheter. Those clinical interventions also include information concerning cultures and antibiotic stewardship, as well as strategies to avoid rehospitalizations, to use alternatives to catheters, and where possible to enhance the communication between long-term care facilities and hospitals. But probably one of the most exciting areas that we saw in this program were the cultural interventions. And this is where we helped staff in long-term care facilities really learn from defects and to understand when they did have a CAUTI or catheter-associated UTI, that they looked at what were the reasons that could have led to that resident developing that infection. Then we spent a lot of time talking about ways to engage senior leaders in making this a priority, and engaging frontline staff and feeling that they were empowered to speak up and to engage all team members, and making sure that information was exchanged in a timely manner and in a way in which it facilitated everyone on the team knowing that they were working together to prevent this type of infection in residents. And then last but not least, really encouraging teamwork and team meetings to continue to keep this issue top of mind. So on the next slide, in a very short method, I want to just say that we really looked carefully at this program, and we recognized early on that we were missing a key partner, a key team member, and that was the residents and the families. And so we looked at how might we, in this program, when we're looking at working with over 500 long-term care facilities, what would be the most expeditious way to engage residents and families in this program? And we looked at the Ombudsman program and said, that's it. We wanted to work with the National Consumer Voice organization, with Ombudsmen across the nation, and equip them with the knowledge and the tools to engage residents and families in infection prevention because of the structure, the networking, the relationships that the local ombudsman already had as a result of their role. We thought, what a better group to engage as partners in this work. And so Robin is going to share with you what that contract looked like, but I can tell you that when we are in the process of completing our final report for this program, it's been a 3-year program, and we've been working closely with the Agency for Healthcare Research and Quality. I can tell you that this is probably one of the proudest moments of this program, is the work that we've done with the National Ombudsman. And so I'm looking forward to hearing not only from 2 of the state ombudsmen that we worked with, but also from others on the call as to how we can continue to spread and expand this program. Robin?
Thanks so much, Sue, and I think you can all hear in Sue's voice her passion and enthusiasm for really involving ombudsmen and engaging residents and families in this work. So next slide, please. So just building on what Sue said, the goal of our part of the project was to work to incorporate ombudsmen into the larger HRET CAUTI project, and to do that as a way to reach nursing home residents and families so we could educate them about CAUTI and infection prevention and empower them to speak up, to get involved, to participate. Next slide. So to do that, we at Consumer Voice worked with HRET and several state ombudsman programs really as a team. As part of Consumer Voice's role, we began by selecting 8 pilot states, 8 state ombudsman programs, and we did that through a very simplified request for proposal process. And on the slide, you can see the states that were selected: California, DC, Georgia, Hawaii, Kentucky, Michigan, Rhode Island, and Vermont. Next slide, please. So we then worked with HRET to prepare those programs for the project. So again, in conjunction with HRET, we conducted a series of 5 webinars with state ombudsmen and their staff to kind of introduce them to the project, to introduce them to CAUTI, to provide information about the different aspects of infection prevention. And then we also required the programs to view other webinars and trainings that HRET had developed and had provided to the participating nursing homes. So the state ombudsman programs were viewing the same materials that the facility staff were exposed to and were educated about. So at the same time, with input and assistance from the state ombudsman, we worked to create a training for local ombudsmen. So this consisted of a master PowerPoint slide deck that had 4 modules to it. The first was recognizing CAUTI, second, alternatives to catheter use, third, preventing CAUTI, and then the last module had to do with the role of the ombudsman. So as I mentioned earlier, the idea was that once the local ombudsmen were trained, they would then in turn educate residents and families about CAUTI and infection prevention and how to engage in infection prevention. So to do that, we developed a resident toolkit that consisted of a brochure about CAUTI and several fact sheets. There were fact sheets on dehydration and urinary tract infections. We also included in the toolkit 2 handouts that we didn't develop, but that had excellent information in them about antibiotic stewardship and about hand washing, hand hygiene, I should actually say. So those fact sheets, that brochure were part of the toolkit along with a ready-to-go presentation for resident councils and family councils, really kind of a grab-and-go concept here. So it included PowerPoint slides and speaking notes. So the idea was the local ombudsman could simply take that and go along with the handouts, and they would not have to sit there and figure out what they're going to present and what to say. It was already done for them. I do want to mention one really exciting part of the project was that in addition to getting really good input from ombudsmen in shaping this consumer information, we went directly to a number of residents and families and got their feedback and suggestions. And this was just incredibly helpful because they, of course, thought of things that we never would have from our end, and their assistance really improved, I think, the final product. So that was certainly one of the highlights of the project. So all of these materials, the training for ombudsman and the toolkit, are available to you on the Consumer Voice website, and we will provide you with a link to that website at the end of today's webinar, so you will have access to everything that was developed during this project. So I've talked about what we at Consumer Voice did, but it was really our partners, the 8 state ombudsman programs, that are at the heart of this project. Next slide, please. So I already noted that our partners participated actively in developing the training and educational materials. But in addition, each state program customized both the training itself and how they delivered the training to meet the needs of their own programs. I mean, I think we all know that there's enormous variation among state ombudsman programs, and it's certainly not one size fits all. So what works for one program will not necessarily work for another. So each program had the freedom to and then tailored the training and then delivered it in a way that worked best for that program. So just to give you one example, some programs felt that they were set up for, and the best approach for them was to conduct a number of regional in-person trainings. On the other hand, there was a program that conducted the training entirely by webinar. And both approaches were successful, both worked, but they were done in a way that really worked for that state ombudsman program. So now I want to talk a little bit, next slide please. Okay, so we've talked about the role of HRET, Consumer Voice, and the 8 state ombudsman partners. I want to talk a little bit about the role of the local ombudsman in CAUTI prevention in general. And I have to say that it actually was a challenge that we had in this project in terms of figuring out and thinking about that role. At the beginning, I think many of the partners really didn't see how CAUTI prevention fit with their work and their role as ombudsman. And I think there was a sense that this was requiring them to be clinicians and basically to take on the role of nursing home staff and not the role of an ombudsman. So we discussed and processed this with the state ombudsman, and I think we're able to frame the work in a way that fits with the duties and responsibilities of Ombudsman. So I want to briefly share that framework with all of you. So as you can see from this first slide, one of the most important points to get across is that ombudsmen are not expected to be clinical experts. We're not expecting you to be clinicians. But you know, the work and the information about CAUTI is more clinically focused, I think, than ombudsmen generally receive. And that's because we want ombudsmen to be familiar with and understand the content, the information, because it really can make a difference in the prevention and treatment of infections. And because we felt it was important for ombudsmen to be exposed to the same kind of information that had been made available to the 500+ facilities that were involved in this project over the past several years. But I think as we talk about the role of the ombudsman and drill down just a little bit right now, I hope that you'll see that the participation in CAUTI prevention really does, I think, reflect the type of activities that all of you as ombudsmen do and do so well every day. So we've broken down the role of the ombudsman with CAUTI into 6 components that I hope will look very familiar to you. Next slide, please. So the first component is to be informed. Know your stuff. So while it's not expected that ombudsmen are experts on every issue, it's important that they be aware of the issues that are facing residents and know at a minimum where to go to get more information. So ombudsmen are really fortunate that they have a broad network available to them and lots of education and resources. So I think it's important to be aware of those resources and that information so folks know where to turn because in some occasions, it may be that ombudsmen have more access to information and resources than facility staff, at least staff in facilities that have not been involved in the CAUTI work. So it's important to be familiar with the risk factors, the symptoms, methods of prevention and treatment for CAUTI because all of that supports ombudsman efforts on behalf of residents if, for example, there are complaints or concerns. And again, while ombudsmen aren't expected to be clinical experts, you know, having an understanding of CAUTI and other infections can really help in trying to analyze a complaint and particularly, I think, in resolving it, because education is a big piece of this work. Next slide, please. So the second component of the ombudsman role is to support individualized or person-centered care in preventing and reducing CAUTI. So ombudsmen focus on helping residents receive individualized or person-centered care, as you all know. So while a facility should be implementing policies and good standards of practice around prevention and treatment of CAUTIs, they also need to be taking into account the individual needs of each resident. So the question becomes, how can an emphasis on person-centered care help to prevent or reduce the incidence of CAUTIs? And one approach, one answer is through adequate and proper care planning. So residents who are at risk for a CAUTI or who may already have CAUTI should be included in the planning, of course, for prevention and or treatment, and a specific plan then developed for that particular person. So ombudsmen are there to provide support to residents in the care planning process, of course, when invited by the resident. Ombudsmen can educate the resident and family about individualized care, what that should look like, and how to ask for it in a care planning meeting. And the ombudsman can also share information with facility staff as appropriate that relates to person-centered care and stress that it's not one size fits all, and that the care needs to be really individualized and tailored for that particular resident. Next slide. The third component relates to one of the core functions of the Ombudsman, and that is to investigate complaints or concerns. So as Ombudsmen become aware of complaints and concerns that are related to CAUTI, they can use the information from the training they receive to help focus the investigation and the resolution efforts. So for instance, they can think about, is this a resident who's at risk for CAUTI or another infection? Does the resident have a CAUTI? How has the facility responded? Is the resident engaged? How about their family? What do they want to have happen? You know, how can they take, as an ombudsman, how can the ombudsman take information from the training and other resources to help in complaint resolution? So, for example, the information can be used to educate staff and residents and families about appropriate responses and treatments. And the training can also help raise ombudsman awareness of overlapping issues, because we know that very often it's not just one single issue that you're looking at in a complaint or concern. There are multiple issues embedded in the presenting concern. So the training can help kind of tease out other issues that might be there, such as maybe dehydration that could cause the resident to be at risk for infection. Next slide, please. So educating residents and families is certainly another core component of the Ombudsman program. So what ombudsmen learn from the training, from all the resources that are available, can be shared with residents and families to help them learn more about infection, to help equip them to ask questions of staff related to prevention or treatment if necessary. So helping residents and families understand good practice, such as hand hygiene, or what treatment should look like, or when maybe treatment might not be appropriate, also helps empower residents and families so that they can know what good practices, what best practices are, and ask that those practices be followed for them. So ombudsmen can provide this information in the ways that they're very familiar at doing, you know, going into the facilities, visiting with residents, handing out brochures and the fact sheets, or by asking to present at a resident and or family council meeting. Next slide. This component of the ombudsman role, the fifth one, has to do with provider education. Again, a very familiar part of ombudsman work. So conducting facility in-service trainings or having discussions with providers is a very important way of helping staff to understand the resident perspective. In doing any facility trainings, ombudsmen can certainly think about teaming up with an infection expert. We've seen that can be a really powerful combination when presenting to residents and families. So in-service trainings, just conversations with staff about, for example, the use of person-centered care and how it can make a difference in reducing infections is another example of education. And again, sharing best practices between providers is also a way to work to improve care. If you identify facilities that are doing a good job and have good policies, you can highlight those with other providers and hopefully move them to provide the best possible care. Next slide, please. Okay, so finally, the last component of ombudsman work that I just want to mention and how it relates to CAUTI has to do with systemic advocacy. And, this can look can take on a number of different forms. It can be addressing a widespread issue in a specific facility, an issue across facilities, raising awareness of an issue in your community. So there are a number of different ways in which ombudsmen can conduct systems advocacy. But I think ombudsmen should think about how the information in this training can be used to impact the prevalence of CAUTIs in the facilities that they work with, how they can promote better preventive practices across facilities by educating residents and families, and what they even might be able to do in terms of policies or perhaps even regulations. So I know that's been very quick, but I do have to admit that fleshing out the role of the ombudsman in CAUTI prevention was something that took some time and some careful consideration. But I think that, and I hope that we turn that challenge into a success, because I want to share with you what one of the partners identified as one of the successes of their work in her state. So next slide, please. Okay, this is what was reported by one of the states. Seeing recognition in the eyes of volunteers as they realized that CAUTI was about basic resident rights, participation by residents, and dignity issues involving everything they were already doing. That made them realize that this new topic fit right in with their work and gave them confidence about pursuing this issue for residents. So I certainly hope that that recognition happened not just in that one state, but across our programs. So now I want to give you a chance to hear from those programs. I want you to hear from two of your colleagues about the work that they did with this project. So you'll hear first from Sherry Culp, Kentucky State Ombudsman, and then from Joe, California State Ombudsman. So Sherry, I'll turn things over to you.
Thank you, Robin. Can you hear me?
Yeah, sound good.
Okay. Next slide, please. I was asked to talk about our successes, and I think one of our successes is definitely that all of our trainings were provided in person. It was really nice to hear from the planners that we had lots of different options in the way this information was presented to our ombudsman. We had just completed a feedback tool with ombudsman asking questions about how they like to receive training, and one of the consistent pieces of feedback was that they did not want us to do conference call webinar training that was 2 hours or longer. So we did in-person trainings. We targeted 3 regions in the state. We went out and did those. And our training was provided to full-time, part-time, and volunteer ombudsmen. We did not reach everyone with the training because there were some issues with scheduling and things like that. Another great success was that it was something new and exciting to talk about. I think that even though ombudsmen typically work a lot of complaints around toileting, I think there were a lot of questions about catheter use and some basic myths and information that was necessary in order to understand more about infection prevention. We definitely all came on the same page at the various trainings that, we want to improve care, and that some of the CAUTI training, revolved around mystery of healthcare acquired infections and catheters, and it was an opportunity for us to learn more. Next slide, please. We had some challenges, and we were able to remedy those challenges. One of the things in the original materials, like Robin had mentioned earlier, the materials as they were first presented to us were basically copies of the materials that were being used with facility staff. So, you know, those of you who've worked with Ombudsman for a while know that we definitely have to carve out our own role in our language in this system. So as the materials were able to be updated and we learned more about the project, we were able to, you know, clarify more of the Ombudsman's role versus a facility staff role in the CAUTI prevention and detection. The presentation length was an issue, like I discussed before. It was more than 2 hours, so we did in-person trainings. The original materials and then after materials were altered. We still got some feedback from people who participated that some of the information was too clinical. But one great thing that came out of some of the information being too clinical is that the nurses, people who are either have active nursing license or maybe they're volunteers and they were, you know, a nurse for 35, 40 years before retiring, you know, there are lots of times as a Ombudsman supervisor that I have kind of had to almost tie a nurse up to keep them from doing too many nursey things, and I'm not sure if that's a word or not, too many nursey things while being an Ombudsman. Well, people who had nursing experience that were in our program, it was definitely an opportunity for them to shine. When we were doing the training, they spoke up a lot. They shared a lot of additional information about how they had worked with catheters and healthcare acquired infections and issues that come up in healthcare facility staff around basic things like hand sanitization, things like that. So it was really good to just let our nurses loose during the training so that we could hear their opinions and utilize their expertise. One of the challenges was, of course, with medical authority, and you know, I think that a lot of ombudsmen sometimes can be concerned about going against white coats and people who are in scrubs regarding clinical and medical information and matters. And you know, I think Joe from California is going to talk a little bit more about this, but one of my staff persons, Mark, during a training session that he was teaching, there was a strong sense that some of the ombudsmen in the room were concerned about medical authority and how could they challenge it. And he just came up with the comparison, hey, Ombudsman, you know, we've worked on restraints, reducing physical restraints, and, you know, there was a time many years ago that everyone who had medical authority, any medical professional would say, this person needs to be tied up, they need to be restrained, or they're going to fall, they're going to get hurt, they're never going to get over this fall. And, you know, sharing information about personalized care and individual rights and what we knew about conditions related to the use of restraints and the results of the use of restraints, we changed that as advocates. So let's look at this CAUTI prevention and identification in the same way. So next slide, please. In customizing the training, in our very first session, we decided to go out and get small containers of hand sanitizer for everyone that was going to be in the room, and we actually did, you know, an exercise where we used hand sanitizer, you know, together as a group and talked about the use of it, and we're able to learn more about the effectiveness of using these alcohol-based hand sanitizers. In another session, we realized each time we did a session, we got feedback from the participants, and we realized that people were confused about the project, the CAUTI project that had been done with facilities, which one of our earlier speakers on the call today was talking about. Over 500 long-term care facilities were involved in receiving information, and some, you know, facilities in every state were provided the information. So, we went back and we found a AHRQ handout about that project so that Ombudsman would know that facilities had already been a part of the beginning of the project and been provided information. And then Mark, one of our staff members that I mentioned before, he felt like people were, some people who didn't have a lot of experience as an ombudsman or had no medical background were really confused about what some of the catheter supplies look like. And so he went to a durable medical equipment company, and I think for $25 he was able to purchase everything that's in the photograph on that slide. Next slide, please. And under our lessons learned in Kentucky, like I mentioned before, making sure that ombudsmen understand that the CAUTI training was first developed for providers, and share a little bit of background information about the project. Understanding the ombudsman role with the information versus the facility staff role, and Robin had several slides about this during her portion of the call today. I think number 4 was one of her slides, educate residents and families, informing them about CAUTI, empowering residents and families, helping residents and families understand when testing for infection is appropriate and appropriate treatment options. Making sure that you are reminding ombudsmen when you're going over this material of what their role is and what you expect them to do with the information, what an ombudsman might detect, what they might see. One of the things when we were doing the training with, Kentucky's divided into 15 districts, and when we were doing training with the 15 local district ombudsmen, the leaders of the local programs, the placement of catheter bags, where catheter bags are and how that impacts the possibility of infection was a topic of great discussion. A lot of people had aha moments where they had seen catheter bags hanging at the wrong height, and there was some really good information in the materials about how that can cause infection. We also had a lot of discussion about residents who have catheters that go in and out of the hospital a lot, how someone may have a problem with the catheter, end up going to a hospital, the hospital may not find a problem, then the resident will be transferred back to the nursing facility. And we talked about how, catheters can be disturbed during transfer, and how that may affect a resident, and how when advocating for a resident's symptoms to be attended to, it wouldn't be uncommon for facility staff to say, we just sent them out to the hospital. The hospital said they had no problem with this catheter. But, we wanted to be armed and prepared to point out that, transferring from a bed in an ER onto a gurney, into an ambulance, off the gurney and into the resident bed, there's definitely plenty of opportunities there for the catheter to get dislodged, or for there to be the bag to be at the wrong height. And those are definitely things that we felt like that we could inform residents and families about to help them have that information. Go forth and do good is one of the bullet points on here. Every time you give somebody a lot of information and you have a call to action, you got to be real specific when they're going out the door of what you want them to do with the information. The fact sheets that I have photographs of here on the slide are absolutely excellent. The ombudsman loved them. The brochure, our ombudsman in Kentucky, they love anything that comes from Consumer Voice, and really appreciate, how good the materials look and how easy they are to read and understand. So getting these handouts into their hands gave them something to go marching out of here with, and gave them something to hand out to begin these discussions. So those are really, really good. Another lesson that we learned is I would encourage you to definitely do this training project in your state, but I would encourage you to take the time to sit down and have multiple people, either in your state office program or throughout your statewide program, learn the materials, because we definitely, it was not the same one person here in our state office teaching the materials. We utilized different people. We had lots of discussions with local district ombudsman program leaders about how we're going to keep this information alive and keep sharing it. We unfortunately had just put out a new training manual that was quite a monster, a training manual in order for people to become certified ombudsmen. So I didn't get a lot of support for including the CAUTI training in the ombudsman certification training manual, but we did talk about putting it on annual schedules for continuing education for ombudsmen. And we have a brand new process since final rule about recertifying ombudsmen, retesting them and giving them continuing education, and how this could be a part of that. So that's all I have to share right now. Thank you guys for listening.
Oh, and thank you, Sherry. I mean, that was it was just exciting to hear all that you did, and some really very helpful lessons learned there. So thank you. Joe, we'll turn it over to you to tell us a little bit about your experiences.
Great, thanks, Robin. In California, we did it a little bit differently, and I'll speak to why. You know, we've got several challenges here. One, just the size of our state and the geography that we've got to cover. We have 35 local ombudsman entities throughout the state that cover all 58 counties, and reaching all of those folks is quite difficult. But what we did was we did one half-day training, which was 3 hours long, for all ombudsman program coordinators. These are the managers of the local ombudsman programs. And based on the feedback that we got at that training, we made some tweaks to the content. We added more interactive types of activities, a couple of YouTube videos that we found on hand washing. We used the AHRQ 5-minute video, which was very good on antibiotic stewardship. We found another video from another YouTube source based on a training put together by some folks in Georgia on catheter-acquired urinary tract infections. And so we really tried to make it more interactive. Following that training for the Ombudsman Program Coordinators, we wanted to really put this on the radar screen of all of our Ombudsman representatives. We've got about 1,000 staff and volunteer Ombudsman representatives throughout the state. So we took our 3-hour training and boiled it down to a 1-hour webinar that was available to all of our Ombudsman representatives, just to get some attention on this issue, because when we first started talking to folks about these things, HAI, CAUTIs, and antibiotic stewardship, we got a lot of blank stares, and people really not knowing what we were talking about, or not seeing a role for the ombudsman to play in this effort. After that 1-hour webinar, we did 5 half-day training sessions throughout the state. All of the sessions were 3 hours long. We invited neighboring ombudsman entities to these 5 cities to join us for the training. So we were in Los Angeles, Fresno, San Jose, West Sacramento, and Chico in the very northern part of our state. In addition to the Ombudsman representatives who attended this training, we also had some surveyors from our California Department of Public Health. We have a memorandum of understanding with Public Health that whenever we offer training to our Ombudsman representatives, we invite public health surveyors to attend as well. And so we had several surveyors at each of these 5 events. Next slide, please. So, as I mentioned earlier, challenges, geography, you know, how were we going to reach all of our folks? And we went into this knowing that it would be pretty difficult at least in this first run, to reach everyone. So we wanted to be strategic in our efforts to educate this first group of ombudsmen. And I want to say thank you again to AHRQ and Consumer Voice and HRET for making the funding available to do this. This was the first time in about 10 years that we were able to get out and do regional training with ombudsman representatives. It was really a great opportunity for us to get back out into the field and connect with volunteer and staff ombudsmen. As I said, people were unsure about what we were training on. HAI, CAUTI, antibiotic steward what? So we really had to establish a baseline, and I think the pre-test and the post-test that we gave our participants really helped measure their level of knowledge and understanding on these issues. As Sherry said earlier, the resources developed by Consumer Voice and AHRQ and HRET were valuable, very valuable resources. And up until getting involved in this project, I hadn't seen anything out there. And so I really appreciated the resources that were developed for this and the resources that were identified for us to use. One of the other challenges that we faced was something that Sherry and Robin both mentioned as well, the challenging clinical content of this information. And I had some reservations about that as well. Back in February of this year, I was at one of our Culture Change Coalition meetings and was reporting out on activities of the State Ombudsman Program, and mentioned that we were involved in this HAI, CAUTI, and antibiotic stewardship training with Consumer Voice and HRET and AHRQ. And Dr. Mike Wasserman, who leads our nursing home project for our Medicare QIO, told me, oh, I'm working on this too. We're training hundreds of facilities throughout the state on these very issues, and this is a part of their scope of work with Medicare. And then someone from our healthcare association chimed in and said, yeah, we're also working on this as well. So we decided to have a separate call after the meeting just to kind of make sure that we were all providing a consistent message to facility staff and to our ombudsman representatives and to residents and families on these very issues. And Dr. Wasserman agreed to help us with the clinical portion of the training, and so he joined us for all of our in-person trainings as well as our webinar, and he was joined by, next slide please, by Rachel Price, who is a gerontologist also with HSAG, and they also added an additional component to the training on QAPI, on QAPI. So that, I think, was really helpful in getting the clinical information across. When you're hearing it from an actual geriatrician, that really helped convince our ombudsman representatives of the importance of our work in this. We reciprocated by participating in HSAG's nursing home training sessions, and so either myself or local ombudsman representatives presented at the trainings for the nursing homes on how we could be involved in supporting their efforts to reduce healthcare acquired infections in CAUTI and to promote antibiotic stewardship. Next slide, please. I think what we learned in California and probably some other states would acknowledge these lessons as well, is that this is an issue that really is not on people's radar screens. There's a lot of education that we need to do of ombudsman representatives, residents, families, and I think we need to frame the problem for them. when we did our training, Dr. Wasserman really used the data to make his points. You know, when he talked about the number of nursing home residents who were on an antibiotic, and the fact that anywhere from 40 to 75% of the time, it's either the wrong antibiotic or it's been inappropriately prescribed. You know, where else is that going to be acceptable? To have 3 out of every 4 times you get a prescription, it's the wrong prescription. When you go to a restaurant and you order a meal, would it be acceptable to have a meal presented to you that's not what you ordered 3 out of every 4 times you go to that restaurant? So I think, you know, as we began to frame the problem, you could see the light bulbs going off. And, you know, as Sherry mentioned earlier, you know, we likened it to our work in eliminating physical restraints and the inappropriate use of antipsychotic medications. We're not clinicians, but yet we can carry the educational resources and a message to residents and families so that they're empowered to speak and to question these practices in facilities. Next, thank you. And you know, I think even though we've completed our 7 training sessions, we want to see this continue, and we're committed to doing another wave of trainings for folks as we have the resources to do so. So thanks again to Consumer Voice and HRET and AHRQ for the assistance in conducting these trainings.
Oh, Joe, thank you so much, and Sherry, thank you again. I think hearing from both Sherry and Joe shows us what wonderful jobs they did in customizing the training to their state. Sherry, I love that you had visual aids in terms of the catheter bags and use the hand sanitizer, and that you tapped into the expertise and knowledge of your ombudsman who were nurses. And Joe, I think that's a wonderful model to partner with your QIO as you did, and it sounds like it was hugely successful. So did you want to add something?
I just wanted to say, I think the other unintended consequence was both the QIO and I realized that, you know, this could be the basis for a lot of other joint training that we do for facilities and for ombudsman representatives. So we see this as the beginning of a new partnership to do mutual training.
Yeah, fabulous, fabulous. So this will have a lasting impact in a number of ways. So that's even more wonderful. So I also want to just take this opportunity to thank and recognize the great work of all the partners who worked on this project. I think everybody worked really hard and did a really good job of getting this information out to Ombudsman. And in just a little bit, when we get to questions, I hope that some of you will share your lessons learned or anything about your experiences with us during that time period. So I want to share just, can we back up to one slide? Let's see. Yes, want to talk just real briefly about project results. We're just in the process of, you know, collecting and analyzing our data, but wanted to just show you some data here. Across the 8 states that have a total of about 2,600 nursing homes, we trained more than 305. We still have a few more numbers to come in, and we definitely saw that the training increased ombudsman knowledge of CAUTI and infection prevention, I think, quite significantly. So you can see the stats here in the training evaluations. People felt that their knowledge increased about signs and symptoms of CAUTI, alternatives to CAUTI, and ways to prevent CAUTI. And then I did think that the pre and post questionnaire, so there was a knowledge questionnaire that ombudsmen who were taking the training completed before the training and then after the training, and I think you can see that there was a significant, I think, increase in that knowledge. So we're feeling very, very good about that and very, very positive. So now let's move to questions and see if there are any questions. So I invite you, if you haven't yet done so and have a question, to enter it into the chat box that is on the right side of your screen. This can also just be a comment that you might have. And again, for those of you from our partner states, if you'd like to share something, anything about your experience with the rest of your colleagues, that would be great. We'd love to hear from you. So, Alicia, have any questions or comments come in yet?
Yeah. So Joan Burke asked, what are the next steps for national participation in non-participating programs?
Well, this is Robin, and that is an excellent question. We're going to touch on that right at the very, very end, but what we would hope is that other state ombudsman programs will take the materials that we've developed, will take the training and use it to train their local ombudsman, and then in turn have their local ombudsman take the information in that resident toolkit and take it out and share it to educate residents and family members. So I think this is very replicable, and we've worked hard to try to put all the pieces together so a state ombudsman who wants to pick this up really doesn't have to put a lot of work into it other than just thinking what format would work best in my state. So we are really hoping that others will pick it up. So thank you for asking that question.
We have another comment from Dawn who says that she was a former CNA and now she's an ombudsman, and so she understands the importance of catheter care and the need to raise the awareness regarding prevention of CAUTI. She will be sharing the information with her facilities.
Oh, that's terrific. Thank you for telling us that you'll be sharing with it. Now, I think your firsthand perspective from having worked in the facility will also add, I think, to the impact that you'll have on residents and families as you share that information. So we'd love to hear how that goes. And thank you.
We don't have any more questions or comments. Oh, yeah. So people can certainly input some more.
Right. Thank you. So please, I would like to particularly invite any of the partner states to maybe share a lesson learned or a success. That's always fun to hear. Or a challenge. Okay. Well, let me just make an announcement. I'll work through a few announcements here. While we see if there are any more questions or any comments. First, I just want to ask both Joe and Sherry if there's anything else you'd like to add.
Sure. I think, you know, I've really invested myself in this issue and in this training and getting the word out. You know, after sitting in on all these PowerPoints and discussions and conference calls and doing 7 rounds of this training, I've personally become neurotic about hand washing and using sanitizer. So on a personal level, I'm involved. But I think, you know, this is really an important issue that we need to address. When you look at the number of people who die each year from C. diff, from avoidable infections, I think this has the potential to get as much attention and deserves as much attention as we've placed in reducing chemical and physical restraints, the use of inappropriate use of antipsychotic medication. I think this issue rises to that level, and I hope my colleagues in other states will seriously take a look at this.
I appreciate your saying that, Joe, because I do agree, because when you look at the number of individual residents who are dying from infections, I mean, that number is right up there with you know, the number of individuals who are still on antipsychotics. So it's very distressing and compelling, and deserving of our attention, I think.
This is Sherry. I agree with Joe. I've become quite a hand washer, hand but that's a good thing. I had my first experience with kidney stones and a severe kidney infection this summer, and I used a lot of this information when I was communicating with my physician about the surgery to remove the kidney stones. Someone in our office had a baby, had a big discussion with her physician about whether or not there would be any catheter use. I think on the systems advocacy part of the presentation, I kind of failed to mention that, you know, we have been working with Consumer Voice on trying to do systems advocacy, legislative advocacy around insufficient staffing and trying to get some kind of staffing standards. And, you know, this information is going to help us. It's going to give a bit more ammunition when we're trying to talk about it. Because, you know, since I have had kidney stones and then a couple months later had a really bad kidney infection, this is a terrible, it feels terrible. It's one of the worst feelings I've ever had in my life, and knocked me, a 42-year-old woman, completely out for over a week at each experience. And I kept thinking about residents where no one would notice these symptoms.
Wow. Wow, that's really powerful, and I think you're right about using it in making the case for staffing, clearly, because I'm so interconnected. So that's an excellent point. Joe had mentioned something about interactivity or interactive exercises, and I want to say that Joe identified, after having done a training, he did let us know that, you know, the way it kind of had originally been set up, there really wasn't anything in there. I mean, they had some really interactive speakers with the QIO involvement, but I appreciated that comment, and so we ended up adding a case scenario, and thanks to Joe, there are any number of really fun video clips, and you would be surprised at how much singing and dancing you can do, and rapping you can do around hand hygiene. So they're actually really, really fun, and certainly liven up the training. So let me just check in with Alicia. Are there any other comments? I think maybe Sue wants to make a comment.
Yeah, sure.
Well, yes, thank you, Robin. I think just before, I know you're going to do a couple of next steps as well as highlight some resources and close out in a few minutes. I just want to make sure and take the opportunity to say on behalf of the Health Research Educational Trust, as well as our funder, the Agency for Healthcare Research and Quality, we just so appreciate the fact that not only have you demonstrated a commitment to this particular topic in the work, but you definitely have demonstrated that this is about partnerships, and it's about empowering the residents and the families and the staff that you work with every day. And when it becomes personal, it truly does become something that you can be passionate about and hopefully will sustain the work. So we're honored and so grateful for your time and your what we know is going to be your continued effort in this area.
So, speaking of continued effort, can we go to the next slide? So, next step. So here's what we are hoping and actually asking for you to do. We would really like you to access and disseminate all the resources that we have on the website. You know, we have the great information, I think, from for residents and families that I think are helpful and right there for you to take and go out and share with the world. Use the training materials. As we just discussed a little bit earlier, take the whole training package and train local ombudsmen in your state. Come to our session about this project at the Consumer Voice Conference. You'll hear from a few more even state partners, and I think it will be a very rich discussion. And this is kind of became sort of our catchphrase, or our catch expression was spread the word that you can't get a CAUTI if you don't have a catheter. It's all about the catheter. So just a couple of other points. Next slide. Want to make sure that you know where to find these resources. This is the link that will take you to the page that has all the resources and training materials we talked about. We'll be sending you an email following this webinar that will give you that link, so don't worry about copying it down. And just as a reminder, we will be giving you the PowerPoint slides as well. Next slide. Just a plea to please complete the webinar survey that will pop up when we're done with this webinar. We always value and appreciate the information that we get back because it helps us improve for the future. This is also important for us in terms of feedback and reporting back to HRET. So we would really appreciate your taking just a few moments, and it's a very short survey. And next slide. Just a thank you to Sue and Joe and Sherry for presenting today. A thank you to all 8 state ombudsman programs for participating, and a big thank you to all of you who took the time from what we know are very, very busy schedules to join us today. And just one last word. Next slide, please. I just want to note that we do this work on infection prevention really in memory of Brian Capshaw, who was an amazing advocate. For those of you who don't know Brian, I mean, he was a nursing home resident in Connecticut and the chair of our leadership council. I mean, he truly epitomized resident engagement. He was one of the most dedicated and ardent advocates we've known at the facility level, the state, and the national level. He was passionate about the work he did and did everything he could to try to make life better for residents until he died way too early as a result of an infection. So our hope is that this work helps prevent the deaths of other residents, because Brian would have wanted that impact to continue. So thank you again for participating in this webinar and for all the hard work and important work that you do every day. So with that, we'll close.